We are here with Professor Bell, Vice Chair of the Department of Cardiovascular Medicine at Mayo Clinic in Rochester, Minnesota. Good morning, Professor. So today we talk about the anti-inflammatory therapies. Actually, yesterday you told us about the role of anti-inflammatory drugs in the context of coronary artery disease, both in the acute and the chronic setting. Could you summarize your topic?
Well, first of all, thank you for inviting me to have this discussion. And yes, yesterday we had a very good discussion about the vulnerable plaque, but in particular, my talk was focused on the use of anti-inflammatory agents. We know there's a well-proven role of inflammation in the setting of coronary atherosclerosis. That's been well proven, and certainly when we look at inflammatory markers, at least historically looking at high sensitivity CRP, we know that for any level of cholesterol, for example, that the event rate is much higher in those who have a persistently high CRP. And so with that as a basis, we know that then trying to interrupt that pathway, we talked about the CANTOS trial, a monoclonal antibody focused on interleukin-1 beta. And it showed that in patients who had coronary disease with an elevated CRP, that we could lower the event rate. The frequency of events was, in absolute terms, relatively small, but it was statistically significant. It was a very well conducted study. The concern with that was that treatment would be very, very expensive, and there was a signal for an increased risk of fatal infections. So we then talked about other agents, more generalized agents, and we spent a lot of time talking about colchicine. And as you know, there are a lot of trials that have looked at colchicine in the acute setting and in the chronic setting. And just really to summarize those, it does appear that the early trials showed a small signal of benefit. It was primarily in a decrease of non-fatal myocardial infarction. And a decrease in the need for urgent revascularization. But again, these event rates were relatively small. Interestingly, there was no difference in mortality. And I think it's really important that we also recognize that compliance with this drug, in terms of side effects, was not always optimal. About 15-20% of patients would discontinue those medications. And the other thing to point out is that there was an increased risk of infections in these patients. Also, there was no improvement in survival. And in fact, in the most recent one, in patients with chronic coronary disease, there was actually a signal of increase in cardiovascular death. And so for those reasons, I think we have to maybe pause and think about who we should target such anti-inflammatory therapy, particularly with respect to colchicine. So in summary, it seemed that the benefits were relatively small, there's potential risk, and there's also expense. And perhaps disappointingly, those studies did not show any really correlation with changes in CRP.
Okay, in this sense, according to what you said, actually, maybe this is a therapy we shouldn't prescribe routinely in our patients. So are there any features we have to consider before prescribing it, or anyway, are there any patients according to their features, or even according to the presence of vulnerable plaques assessed with the intracoronary imaging?
So maybe we just focus on that last question, because that's really important. It's very exciting. We heard a lot of discussion about how to identify the vulnerable plaque, and it was very much focused yesterday by my co-presenters on intracoronary invasive imaging. And I think we have rich data really showing the plaques that are vulnerable. But this is just one point in time, and they're not always going to result in acute myocardial infarction. So I think that targeting the patients that have had intravascular imaging for anti-inflammatory agents, I think that's very premature. We just don't know enough about that. We talked about, are there any data to, if you could do PCI on those patients, or is there some drug that you can infuse into that? But this is not something that is ready for routine use, and a lot of trials are looking at it. And as I said, I think this is impractical for the main population. But getting back to the first question, I think that the patients who have presented with acute myocardial infarction do not think that these are the patients that the trials have really shown us that it doesn't really help in those patients. It doesn't help in the patients who have decreased renal function. So GFRs less than 60 do not seem to be any benefit. And so we probably should be more focused on the patients who have chronic coronary disease, like was shown in the last trial, the Lodoco 2 trial. And so these are patients who maybe remotely had an MI. But even so, it's the results of that trial, I think, still should give us pause, because the absolute benefit was relatively small. And again, we don't really know what their baseline lipids were, their blood pressure, CRP wasn't measured, so we're not even sure there's a plausible biologic explanation. We also need to keep in mind that, at least in the United States, colchicine is an expensive drug. And then, particularly in that acute MI patient, we have many other drugs that they have: beta blockers, ACE inhibitors, statins, PCSK9 inhibitors. They all decrease CRP. So whether there's any incremental benefit of colchicine remains to be seen. So, to be honest, I'm not sure who we should be targeting this drug to. But I think that they need to be on full guideline-directed medical therapy. We need to be sure that their LDL cholesterol is in U.S. units is 55 milligrams per deciliter or less. And maybe then, perhaps if they still have a high CRP, maybe that's a patient that we should target. But I'm just not sure we have really identified a group of patients that we should really focus this treatment on. And so at the moment, I'm not sure that this is a drug that I would be prescribing routinely. And in fact, the current consensus guidelines from just this year give it a 2B recommendation. So perhaps disappointing, and I'm looking forward to other drugs, other novel drugs, or maybe novel biomarkers that will actually identify patients who will be really benefited, will benefit from such treatment.
Okay, thank you very much, Professor. We're looking forward to have you here also next year. Thank you very much.
Thank you for asking me.